Hello, my name is Ruth Woolley, and I chose adenocarcinoma of the esophagus. I chose this disease because I recently took care of a patient with this diagnosis. For this video, I will refer to the patient as SJ. SJ is a 50-year-old married Caucasian male. He has been unemployed for over 6 months and lives with his wife and mother. He is a current smoker of at least a pack per day and drinks alcohol daily. SJ presented to our ED from an outside hospital with dysphagia. SJ stated that his difficulty swallowing started when he coughed up a piece of hot dog. He also has complaints of severe heartburn, nausea, vomiting, and a 15-pound weight loss. From the physical examination, SJ appeared chronically ill with bilateral temporal wasting noted. For his eyes, there was no scleral icterus or conjunctivitis, and he was perla at a 3 millimeter. His posterior pharynx was without erythema or exudate. His neck was supple, no jugular vein distension, and no lymphadenopathy. His trachea was midline. Respiratory symmetric expansion, non-labored, lungs clear to oscillation bilaterally. Cardiac, regular rate and rhythm, S1, S2 distinct, no murmur, rubs, or gallop. Cap refill was less than 2 seconds. No carotid bruit, no cyanosis or edema noted on extremities. Radial pulses palpable +2 bilaterally. Pedal pulses palpable +2 bilaterally. Gastrointestine, soft, non-tender, non-distended, no palpable mass, no rebound tenderness. Bowel sounds present in all 4 quadrants. Neuro, alert and oriented ×4. Musculoskeletal, normal range of motion, no atrophy, and extremities are symmetric. His past medical history is iron deficiency anemia, splenic vein thrombosis and splenic infarcts, hypertension, a left pleural effusion from a previous thoracentesis, and depression. SJ's mother has hypertension, GERD, hyperlipidemia, and is obese. His father's past medical history is unknown. SJ's medications currently famotidine 20 milligrams orally twice a day, folic acid 1 milligram once a day, metoprolol 25 milligrams oral twice a day, Mitrazapine 15 milligrams once a day at bedtime, a multivitamin, as well as Senna 8.8 milligrams orally twice a day. According to our text, story states esophageal cancer is usually squamous cell carcinoma or adenocarcinoma, and it most often affects men. Incident rates of esophageal cancer have remained steady, but mortality rates have increased since 1980. According to the American Cancer Society, esophageal cancer is the 7th leading cause of cancer death in men, even though it did not make the top 10 cancers in men. The Mayo Clinic states adenocarcinoma begins in the cells of mucus-secreting glands in the esophagus. Adenocarcinoma occurs most often in the lower portion of the esophagus. Adenocarcinoma is the most common form of esophageal cancer in the United States, and it affects primarily white men. The risk factors are having GERD, smoking, having precancerous changes in the cells of the esophagus, known as Barrett's esophagus, being obese, drinking alcohol, having bile reflux, having difficulty swallowing. The signs and symptoms are weight loss without trying, worsening indigestion or heartburn, chest pain, pressure or burning, coughing, hoarseness, and difficulty swallowing, dysphagia. Early esophageal cancer typically causes no signs or symptoms. SJ's primary complaints of dysphagia, heartburn, nausea, and vomiting are consistent with the clinical manifestations of adenocarcinoma of the esophagus. The physicians performed an EGD and biopsied SJ's esophageal tissue. A CT scan of the chest showed mild dilation of the esophagus with circumferential wall thickening throughout the thoracic esophagus. Based on these findings, a metallic stent was placed at the gastroesophageal junction. Oncology was consulted regarding a plan to start radiation. A dietary consult was placed to address SJ's moderate protein-calorie malnutrition. At this time, the patient is NPO with LR running at 42 milliliters an hour and is awaiting follow-up. Current labs: sodium 140, calcium 102, calcium 9.3, chloride 102, BUN 9, potassium 3.7, CO2 26, creatinine 0.54, glucose 109, white blood cell count 11.09, hemoglobin 7.1, hematocrit 24.3, and platelets 682. This patient became increasingly agitated, requesting food and something to drink. Even though the patient came in complaining of dysphagia, it was difficult explaining to him why it was so important to remain in PO until a plan was in place. The patient also requested to go outside to smoke on multiple occasions. I explained to him that it would be in his best interest to remain in his room so that when the various teams came by to discuss his plan of care, that he would be there to participate. Unfortunately, my attempts to educate the patient regarding his diagnosis seemed to go in one ear and out the other. I believe this is due to a lack of knowledge regarding healthcare in general. These are challenges I face every day with non-compliant patients. Thank you for listening to my case study.